this next section, I'm actually going to discuss cystic fibrosis. I also expect to discuss bronchiectasis and indeed respiratory failures. And if depending on how things go in terms of the amount of space that I have, I will also quickly discuss sleep apnea. So starting with cystic fibrosis, which is the first topic that I'm going to do. I know that in the last section I said I was going to do sleep apnea first, but I don't know, I just decided to do cystic fibrosis first. So cystic fibrosis is a genetic condition arising from a mutation in the cystic fibrosis transmembrane conductance regulator gene. So we call it the cystic fibrosis transmembrane conductance regulator gene. That is found on chromosome, on the long arm of chromosome 7. The inheritance pattern of cystic fibrosis is actually autosomal recessive. I wonder if I need to change a pen. I think this pen is a bit. Is autosomal recessive, and that means that you need two carriers because it's obviously recessive, so you will need you will need, okay, say if this was this, because you are meeting CF and CF and CF. So you will have CF. Oh, I've done it wrong actually. So this is the same mother, and this will be the father here. So you have CF. So you have CF, and then CFF, and then you have CF. So these are the affected children, and so there is a 25% chance that if both parents are carriers, the child will have the disease. Cystic fibrosis mostly affects males, like the male gender. Females are affected as well, but it's mostly a disease of males, and it's mostly a disease of Caucasians. So there is a very, very low, really almost nothing of perhaps Africans or perhaps Hispanics getting this disease. However, Caucasians are the most people affected by cystic fibrosis, particularly male children. So this gene, the CF, I'll just call it, so it is found on the long arm of chromosome 7, and it actually encodes for the a channel, an ion channel for chlorines and other halogens. And if you were to remember, halogens are, I think they're group 7 of the periodic table, and they include fluoride and iodine and I've forgotten actually, and bromide. I remember bromide. I know there's another one that I've forgotten. I think it's thiocyanate as well, which passes through. It's not a halogen, but it does pass through the channel. So it's chloride specifically this ion channel encodes for. But obviously the other halogens as well pass through the ion channels in the cell. So what this channel actually does, because the protein is actually called the CFTR, and what it actually does is that it inserts on the outer surface of the cell membrane, and it allows for chloride to move out of the intracellular aspect of the cell into the extracellular surface. And when that happens, then ion regulation occurs. So there is proper ion regulation, and there is proper regulation of water movement as well. So really, it is an important channel. So its effect, this mutation causes a number of phenotypes that are observed from that mutation. So the first one can be from a deletion of sequence 508, again on the long arm of the chromosome 7. And the deletion actually results in a protein that misfolds, and therefore it's just degraded by the regulatory mechanisms of the cell, degradation, and therefore the channel is completely absent. Another option is for a truncated ion to be made. So it's truncated due to early termination, and again is a misfunction, or some could function but not function optimally and not function very well. So because some truncated termination, some truncated proteins can have retain some of the functional aspects if the amino acid sequence for the function is actually preserved. And then what we also have is fewer copies of the gene being made. Fewer copies, which means that we have fewer than normal ion channels being inserted. So we have reduced number of channels being inserted onto the membrane. Another effect is a channel that actually transcribes. The channel does transcribe. I'll have to change this pen, I'm so sorry. The channel does transcribe. However, it's unable to actually use ATP. So it's unable to use or to respond to use or respond to ATP, and it follows that if it cannot use ATP, therefore cannot use cyclic AMP to actually catalyze all the cell processes that are required. Because if we remember, ATP, the use of ATP in the cell is under cyclic adenylate, whereby ATP comes in and it is hydrolyzed into cyclic AMP by a removal of a phosphate, and that cyclic AMP is the one that then catalyzes the activation of all the kinases, which then causes enzymes. Well, there are enzymes which then cause phosphorylation and the catalysis and the catalyzation of whatever effect the cell has to make. So then the other effect is a high turnover of the cell, of the channel. I can't believe I keep saying the cell. So there is a high turnover of the channel, which means that because there is such a high turnover, you know, there is quicker degradation, and really it's just as good as non-functional because it's not functioning at optimal level. So then when there is too much chloride in the cell, it means that, you know, it then attracts sodium as well. So we end up with a lot of sodium chloride and water. But what it actually means for the organs that are affected, which includes the lungs, the pancreas, and the GI and GU. I'll just quickly do that. So what it means for the lungs is that the secretions that are made, remember the lungs, you know, the smaller airways, actually secrete mucus to keep the lungs clean and to warm the air, and obviously for defense against any inhaled pathogens and indeed foreign objects like dust particles. So it is a defense mechanism that we have naturally. So the mucus that's secreted by the lungs, because there is less fluid, ends up being very thick and viscous as well. High viscosity. And because of that, it actually then gets trapped and causes plaques, which then block passages. And blockade of passages obviously then means that, you know, things cannot be cleared out of the lungs. It also means that we then create a breeding surface for pathogens to come in and breed. And it also means that you then stimulate an inflammatory response. And indeed, this is the underlying pathology in terms of what happens in the lung. I will talk about it in a minute. I'll expand on that in a minute. So in the pancreas, we also have obviously enzymes that we need to digest and absorb nutrition. So enzyme for nutrition, now absorption. And the pancreas also makes insulin, and obviously regulates, you know, glucagon as well. But the enzymes that are made by pancreas, they are then kept inside the pancreas because again, as with what happens in the lungs, there is blockage. So I'll just write plaques, you know, just block the enzymes, and so you end up with autodigestion of the pancreas, leading to pancreatitis. You end up as well, you know, with poor insulin regulation, leading to things like diabetes. Poor insulin regulation leading to things like diabetes. And then you also end up with poor absorption, because well, always talk about things like lipases. So with poor absorption of fat soluble vitamins, including vitamin A, vitamin E, vitamin K, and vitamin D, of course. So again, you know, just a quick look at that. Vitamin A is actually quite useful for the eyesight and for antioxidants as well. Vitamin E is very useful for antioxidants, but more important, it is a coenzyme together with vitamin A. They are both coenzymes for many vital cell processes, so they are quite, you know, useful enzymes to have. Vitamin K is actually quite useful for coagulation, specifically for coagulation factors, which are vitamin K dependent, 2, 7, 9, and 10. So then, therefore, obviously, this person, you know, people affected will have problems with clotting, and they will have bruising, bleeding, and similar problems, obviously, because if we remember, you know, factor 10 particularly is the common pathway of the clotting cascade, and without it, it's really hard to actually produce that clot and, you know, stop a bleed. And then vitamin D is useful for a number of enzymes, a lot of enzymes, including things like testosterone, cholesterol, you know, I'll just say a huge number of enzymes. And indeed, you know, preserving of bone density. So that is another useful enzyme. Then I will expand on that as I go. And then in the GI, people will have a lot of, if we start from a baby will have meconium ileus, which means that they won't pass that first stool that babies pass when they are born. They will also have a rectal prolapse due to the production of a lot of stools that become impacted inside. So they will also have distension of the stomach, and obviously GI pain, and obviously there will be poor nutritional absorption. And then they will also have diarrhea. And when I say diarrhea, I mean fatty, you know, foul smelling diarrhea, and they'll be passing a lot of wind, again fatty and foul smelling. And then in the GU, usually males will become infertile because usually the vas deferens does not work properly, or it's just not there. So in the vas deferens obviously carries the sperm from the testes out through the urethra. So without the vas deferens, there is no, you know, passage for sperm. So now going back to what happens, the pathology that actually happens in the lungs. I just want to say, obviously, the plugging, you know, of ducts is similar in terms of, you know, all the blockages that happen. The other thing which I forgot is that the liver, bile will become blocked as well. And that can lead to cirrhosis. And then sweat glands also become you know, clogged with a lot of sodium chloride due to, you know, not being able to get rid of the chlorine and chloride, and that chloride recruiting the sodium to make sodium chloride and water. So people with CF will have, you know, will perspire a lot. So and the perspiration will be very salty. And this is one of the diagnostic criteria, particularly say for younger children. It's usually the parents who come in and say, well, our son, our son tastes salty. And in doing that, obviously, that is a trigger. When you then look at other symptoms and you look at the family history, then the picture becomes much more apparent that this is someone who is suspected of having cystic fibrosis. And then tests that have to be done will include genetic testing and the sweat test. The sweat test again, so the diagnostic investigations are the genetic testing and the sweat test. And then this is put together with things like, say if it's an older child, things like having COPD, like features of a disease, chronic cough, productive, and things like failure to thrive, and weight loss, in spite of, a good normal appetite and a family history. And another thing really to mention in terms of investigations and diagnostics is that in the UK there is routine screening for cystic fibrosis. So all male children are routinely screened, and that usually catches a lot of children with who are predisposed to the condition. And then if for whatever, sometimes if it's a false negative, which does happen at times, then the later testing is the above. Or indeed the screening as well. After screening, you can then confirm the findings of a positive result with a sweat test or with genetic testing. So so the sweat test really is just based on checking the sodium chloride levels of the sweat, and if they are increased, I think it has to be above 60 millimoles. Don't compare that please, but it's higher than normal. And also they also check the thiocyanate in the saliva again, and it is increased as well because it actually uses the same channel to move in and out of the cell. So once before testing, if it's someone older, or even after testing, cystic fibrosis, or even say in people who are carriers, who know that they are carriers, has genetic counseling is actually offered. And what it actually does is discuss the disease, because it is a genetic disease, and discuss its effects, the prognosis, and outlook. Well, prognosis is outlook, but then in terms of, say, if someone wanted to have a family later on in life, say if a child who's affected wanted to have a family, obviously this can then, be discussed with obviously the parents. And then if it's someone older, you will then discuss about having a family. If they are affected, usually with men, they could be infertile. With females, they can actually have children, but obviously they will have to have a lot of support in terms of even gestational diabetes, and indeed just carrying a child to term, everything involved with pregnancy. So obviously the inheritance will have to be discussed, and all other issues that are involved, you know, in finding out that you have, you know, a disease that is incurable, and how to manage and live with that, and what to expect in life. So having said that, I think I forgot to mention that cystic fibrosis is actually incurable, but manageable. And patients usually live up to, I'll say, up to age 40 at the moment. However, obviously genetic studies are being done, I think, to probably try and replace the deletion, and to try and you know, fix the gene, correct the gene in order to overcome that mutation. But it is incurable. You can treat it, but yeah, people, you know, are not expected to survive into old age, I would say. So really what happens is that the underlying pathology is that the resident macrophages in the mucus, remember there is a build-up of mucus, there is a build-up of thick, sticky mucus. So that build-up of thick, sticky mucus causes the activation of resident macrophages, and also it causes the epithelium to actually secrete IL-8 and other cytokines. So the secretion of IL-8 recruits neutrophils, resulting in a cell-mediated inflammatory response. And obviously, the neutrophils will also, you know, secrete even more cytokines to also auto-activate. So with neutrophils, you will have a lot of proteases that obviously digest proteins, and you end up with because you are obviously the thick and sticky mucus is there, it is being produced, and it's really not leaving the bronchi. So this is a disease of the bronchi and bronchioles. So because it's not leaving, so you end up with you know, resident microbes, particularly in cystic fibrosis. People usually have Pseudomonas. I can't remember how to spell this word. Genosa. There probably is an E missing somewhere, and the Genosa. So that's the most Pseudomonas is the most 80% of patients will have a resident Pseudomonas infection in their airways, And what that means is obviously that they are prone to then having, developing resistance to any treatment that is being given, because this Pseudomonas can then undergo changes that will allow it to resist treatment. And then what happens with having those microbes and, and mucus means that there is an unremitting inflammation. So you end up with a vicious cycle of there is infection, there is inflammation, inflammation. It just goes on and on and on and on. And what that then means is that patients will present with a productive cough when there is an infection, but the cough is always there because of the sticky mucus. So they're trying to clear the airways and coughing a lot just to try and clear the airways. And they also have dyspnea. They will have a wheeze sometimes, but mostly they will have crackles at lung bases. So that's I'm too far to draw, I think. So they will have productive cough, shortness of breath, and crackles at lung bases. Cystic fibrosis initially is an obstructive disease. And because it is an obstructive disease, there is reduced FEV1, and indeed the FEV1 to F is less than 0.7. So it has a restrictive picture, an obstructive picture initially. But as it progresses, towards the end of the disease, patients will then switch to restrictive. And this is due to where, both FEV1 and FVC are both reduced. So the ratio will normalize. And that is really due to fibrosis that occurs due to the continuous inflammation that they have. Another thing to mention in terms of pulmonary features, these patients will have dyspnea and cyanosis, of course. And they will then develop clubbing of the digits. So this is what happens in the lungs, and they are in pain and they cough a lot. If you meet a cystic fibrosis person, the coughing is really hard, and it looks painful. I've seen people with it. It looks painful because they're coughing quite a lot and using up a lot of energy in that coughing. And obviously this cough as well, the coughing that they do, trying to clear the lungs, obviously uses up a lot of energy, which is really what causes